It's great to see everybody here. We got a tremendous, when we opened this up and we said, well, we have limited seating for this special lecture. I tell you, it was fully subscribed in a matter of minutes. So it just goes to show when you have a star coming to the school, it's just great to see everybody here. So we're very fortunate to welcome Dr. Yik-Ying Teo, better known as YY, of the Dean of the Swee Hock School of Public Health and Vice President of Global Health at the National University of Singapore. I visited YY and his school. When was that? I'm trying to...
August last year.
August, it was just August last year. So it was just about a year ago. Yeah. Time flies. But it was a great visit. And I was deeply impressed that all I saw the work that he and his colleagues were doing at the Swee Hock School of Public Health. And we just had an opportunity to meet with YY and his colleagues this morning. And I was impressed to see, even just in that short period of time over the last year, how much the school has done to increase its footprint. So it was just great to hear of all the wonderful things they have done. The School of Public Health at NUS is at the forefront of education, discovery, and practice, making an impact throughout Singapore and, very importantly, in the ASEAN region and even beyond. So I'm very pleased to welcome YY as well as his colleagues, Drs. Liao and Dr. Cook, who are here at the front table. It's just a pleasure for them to be here. YY comes to his current role as Dean of the School of Public Health with a broad health experience. He's worked to advance genetic technologies to control and eliminate infectious diseases, including malaria and tuberculosis. He's also been involved in training and capacity development of research fellows from African and Southeast Asian countries. Prior to his deanship, he led his school's Center on Infectious Disease Epidemiology and was the founding director of its Center for Health Services and Policy Research. So you can see he has and continues to have a very broad interest and expertise in public health. Currently, he serves as a member of the International Organizing Committee for the Prince Mahidol Award Conference, as well as the M8 Alliance, which is the academic foundation for the World Health Summit that many of you are familiar with. He is also co-director for the Asia Pacific Academic Consortium for Public Health's Collaborating Centers for Health Promotion, and he sits on the Global Coalition of Deans of Schools of Public Health. As Dean of Swee Hock, YY is building on his school's decades of experience in research, training, and practice to continue to foster healthy communities in Singapore and, again, in the region and around the world. Under his leadership, Swee Hock is impacting public health programs and policies through its robust training, its translational research, and its collaborative work across disciplines and sectors. I am so excited we get to hear from YY on the vital role of academic governmental relationships, one that's very important to his school and important for all of us in public health. We know that stronger partnerships between universities and government will be key to developing a healthier, safer future that we all obviously want to see. And I know YY has a lot of ideas how to improve and enhance those relationships. So Dean YY, thank you so much again for traveling here a long distance and together with your colleagues. And we're really looking forward to your talk. So YY.
Right, good afternoon, everyone. Thank you very much, Dean McKenzie, for your very, very kind introduction to myself and my colleagues from Singapore. It's always amazing and a real privilege to be able to address a crowd with public health people. And Furthermore, in the top school of public health, arguably in the world, definitely in the United States. Today, I wanted to talk about academic government partnerships in public health, which I think in Hopkins Bloomberg School of Public Health, you'll be very familiar with. But I wanted to start off perhaps to talk about the mission statements of Hopkins University and my university, where I come from, the National University of Singapore. So in Hopkins, we talk about education, we talk about research, but very importantly, we talk about bringing the benefits of discovery to the world. Just like how in National University of Singapore, we talk about innovation, enterprise, but again, trying to build a better world, whether it is in Singapore or the societies out there. Now, these are the mission statements, and how do we actually live up to that mission statement? We, as universities, we do three things. The first, of course, is we teach, we educate, we build capacity in different areas, not just training future leaders, but also trying to educate current leaders on how to make do with what we have in the world right now. Importantly, we also do research and innovation. I think we know this very well. But I wanted to focus on the third point, which is really around practice and social impact. Because increasingly, universities worldwide are being judged, ranked, and assessed on the basis of how well we do in research, how well we teach, but very little it's talked about or is even measured when we start to think about practice and social impact. And if we look back at the mission statement earlier on that I introduced, you would realize that universities actually start off with that aspiration of looking at how can we serve the community, the world, better beyond just teaching and research, but also looking at social impact. So if we now start to look at what is the world that you and I live in right now, there are megatrends. I've listed 6 megatrends, and I'm pretty sure many of you would think about more megatrends. And I'll just highlight that a lot of the impact that we think to health of individuals, to communities, or to countries actually will arise because of some of these megatrends that are happening in the world. Changing demography. I think I learned today that one of the priority programs and areas that Hopkins is looking at, Bloomberg School of Public Health is looking at, is healthy aging. And I think in countries worldwide, we are starting to see this problem of an inverted population pyramid. I think if we think about the challenge of communicable diseases or maternal child health, we haven't really thought very deeply about what non-communicable diseases, what mental disorders will bring if you have an inverted pyramid with a lot more elderly people out there than a young population that can support. Rapid urbanization, advances in technologies, geopolitics, climate, rising distrust, mistrust, and misinformation and disinformation. I usually have to be a little bit careful when I'm presenting this in the States, when I talk about rising distrust, particularly rising distrust in state actors, in national agencies of health, in national leaders. Because this is going to confound a lot more of the public health polycrisis that we think about, whether it is antimicrobial resistance, it's all the challenges from climate change. But if you have rising mistrust and disinformation out there, it is going to compound the world in a compound the difficulties in handling health crisis in a much more profound way that we've seen so far. So when we start to think about this 21st century threats to global health, this is just a very quick illustration of some of the impact and the uncertainty. I think the question then comes back again, that as academics, as universities, not necessarily just working in public health, but in a broad range of disciplines out there, are we starting to think about how our work fundamentally fits into this world of megatrends that we're seeing in the 21st century, bringing new threats or actually existing threats to health, to populations out there? So very humbled to be standing in front of a poster that says protecting health, saving lives, millions at a time. And I think we seriously need to start thinking about some of these megatrends out there and how we should be incorporating this development in our work. Now, I started talking about Hopkins and National University of Singapore, NUS. And I think we share very similar traits and characteristics in the sense that we are universities with multiple disciplines. And how do we integrate all of these disciplines to really tackle some of the world's problems out there? Now, I've talked about the university's vision. It's more important to actually talk about public health vision in top schools of public health. So I'm going to be very presumptuous here and rather cheeky. So I've listed Hopkins, I've listed London School of Hygiene and Tropical Medicine, which in our opinion leads public health in the European context. And I would aspirationally hope that my School of Public Health in the National University of Singapore could be seen as the top school of public health in Asia Pacific. So then, these are the mission statements that I've got from 3 schools of public health, in my context, the top schools of public health around the world. If you look at Hopkins, of course, if you look across all 3 schools, we talk about education, we talk about research as well, but importantly, we talk about advancing the public's health here in Bloomberg School of Public Health. Over at the London School, we talk about translation of knowledge into policies and practice. And then in Singapore, in my own school, we talk about turning discovery into healthier communities. So that is the landscape that we started off. That's the mission statements that schools of public health have. But the question is, have our lens actually changed, or how would we need to prioritize our work in order to live up to these mission statements? I think all 3 schools do exceptionally well in teaching, in research, in capacity building. But increasingly, what do we need to actually look into this space of social impact and practice and impact to policies and programs? So I will now switch a little bit now to focus on what do governments think about when they think about health policies or when they design their national programs. And I think usually sensible governments like to think about programs or policies that are sustainable. It doesn't bankrupt the government in the long term. They hope that they put forward protection that is adequate, that is enough to look after people, regardless of their age, from young to the old. And I think most governments aspire towards equity and fairness, that it should cover populations properly without gaps in coverage. And finally, it should be efficient in the sense of providing outcomes, results that are cost-effective for governments, balancing what is good out there and choosing the better option on cost efficiency. And I think these are the aspirations which I typically summarize as safe government policies, SAFE. And I think this is very much reflected when we start to look at what WHO put forward in terms of universal health coverage, in terms of safe universal health coverage as well. But the problem is, in the world out there right now, I think when we start to think about health policies, even health financing strategies, there's often this tendency to veer towards what is popular to the people and what seems to be the sentiments out there. And I think when we start to look at development in health policies in my part of the world, in Asia Pacific, I've just 2 examples here on India's health financing and also in Thailand's pivot towards medical marijuana that is rapidly degenerating into recreational marijuana. I think there is a lot of politics involved, because if I use the example of Thailand, as part of their manifesto in election, Thailand's politicians actually looked at medical marijuana as an opportunity for the people to gain wealth and to expand their capture of the electorate votes. So when the prevailing government was elected, and then I think they live up to the promise, which is on medical marijuana. So that is the responsible government who live up to their promise during the election. But what happens when there is a danger that medical marijuana now slides towards recreational marijuana? I think those are challenges that we need to think about. Health is fundamentally politics. Now, if we now try and combine the priorities from both academia and from governments, you would realize that in academia, what do professors, researchers get benchmarked on? A lot of times, when it's research, it's on publications and grants. When it's coming to teaching, it's on the quality of teaching as reflected by the students, the design of your curriculum. And even when we think about service, it is somewhat insular that we think about benchmarking service to the university, to the college, to the faculty, to the department. But for governments, the priorities are completely different. When they think about coming up with health policies, they think about, is it popular? Can it be accepted? Is there any evidence that it will work? Will it work in my country? How much would it cost me to run? And how do I implement this? So you will notice that from the onset, government priorities and the priorities of academics like me are completely different in the beginning. And how would we institute a system that will try and bring two groups of people together? And again, this is where I will talk about what happens when there are policies that are rushed nationally, when there is a lack of independent evaluation, whether it is the dengue vaccine in the Philippines or whether it is permitting the use of electronic cigarettes. In my country, Singapore, we currently ban the use of electronic cigarettes or vaping. It's a complete ban, so you can't find any shops that sells it legally in Singapore. But yet, vaping is an increasing problem in Singapore because it is so easy for me to bring in vaping products, vaping devices. You could order it online. It's very difficult to police. But the reality is that I think the world hasn't really understood what is the true impact and the true cost when it comes to the use of alternative products such as electronic cigarettes. Now, I asked that question, how can governments and academia work together to formulate what I would call safe health policies? And it could be a range, whether it is on novel ways to identify diabetic people, on vaccinating against HPV and to prevent cervical cancer, sugar tax, or tobacco control laws. These are just some of the examples. So the next 10 minutes or so, I will try and share perhaps 4 perspectives of how academia can actually benefit governments, policymakers. And let's start off with the first thing, on really helping to set priorities. Now, I talked about earlier on, the world is facing megatrends. And if I look at this figure is actually a slide taken from Singapore's Ministries of Health. Across the horizontal axis, you have a measure of importance. How important is a development? Could be a national development happening locally in Singapore, could be a development that's happening worldwide as a trend, one of the mega trends. Across the vertical axis is a measure of uncertainty. And just to share, this slide was actually introduced and shared in 2013, 2014. And if I could just direct you to look at what is on the top right corner. In 2014, policymakers were already thinking that natural pathogen evolution, hugely uncertain, but potentially quite catastrophic in its impact to health of a population, to a community. And of course, now speaking 3 years after COVID-19, I think we realize that, in fact, this is indeed a threat. But let's look at what else is on this figure. You have aging population. I started talking about one of the mega trends, which is changing population demography. Aging population, there is absolutely no uncertainty out there, because if I look at the birth statistics right now for the past 50 years, I know exactly how the population pyramid looks like. And if there is no migration patterns, that is what your country or my country will be faced with in 10, 20, 30 years in terms of aging population. Zero uncertainty. Governments have all the information out there to prepare for it. But one of the questions is how many governments actually perhaps in Europe, in North America, are thinking about aging populations in mapping out their national health priorities. In my country, we have to, because we are facing some of the challenges from an aging population in countries like China, Thailand, territories like Taiwan. They are faced with a real crisis from aging population. And I think that is where what it's going to be the strategy from a health policy perspective in taking care of that. And then we have antibiotic resistance, we have changes in human behavior, increasing population, food industry practices. And if I just zoom into one group of this, and now try and condense some of the information I talk about. So I talk about aging population, and what that means is life expectancy is changing, not necessarily always in the manner that we would prefer, because healthy life expectancy still lags behind life expectancy, at least in my country, by about 10 years, by a decade. So people are passing on at around 84, 85, but about 10 years before that, they are starting to be down with quite debilitating chronic conditions that it's not good for their quality of life. From a country's perspective, it's going to cost the country a lot more to look after the health of these people. And I talk about the changing demography, right? And I've shown you one of the characteristics that was mapped out in the priority setting on changing human behavior. I think we are eating a lot more. We are exercising a lot less. So obesity rates worldwide, in the United States, even in Singapore, it's going up. And what that means to a problem like diabetes is that we are now going to see a massive increase in the burden of just one chronic condition that I talk about, which is diabetes. I haven't included hypertension from salt consumption. I haven't talked about high blood cholesterol, cancers. So if we know that diabetic burden is going to increase, how do we raise this awareness to policymakers? And typically policymakers, if you tell them that more people are going to be down with diabetes, it may not be very exciting to them. But if you now tell them that more people are going to be down with diabetes, and it will cost your government 1%, 2% of your health budget to look after this group of people on an annual recurrent basis. So in Singapore, just back in 2016, we estimated the cost to be about $1.5 billion. So you could see, and this cost is projected to increase to $2.5 billion on a recurrent basis every year, just managing diabetes alone, not including hypertension, not including other conditions. I think that's where governments sit up, and then they realize that this is a problem, because when we think about the problem of diabetes, it is not just a medicalized problem. It is a social problem as well, because human potential drops. That with a condition, you are less productive at work. From a national perspective, it leads to national productivity losses. And I think countries like mine, Singapore, where we have a small population to begin with, every capable manpower or person counts. And we want to extract the value of every person as much as we can. And how do we do so? We have to try and minimize some of these chronic conditions. So Singapore, we launched a war against diabetes, which was quite interesting because the war against diabetes was launched by a health minister, and Singapore, we have been very blessed and privileged that we were in a region where the defense minister never had to announce any war. But the health minister was the first person to announce a war against diabetes. And in fact, our prime minister actually felt that it was a very important issue that in his annual State of the Union equivalent address, he actually talked about diabetes and the cost of neglecting this condition in a country like Singapore. And that immediately pivoted health policies in the country to really start thinking about how do we address this from the prevention, from the screening, control, management, avoiding complications, the whole range of public health activities that we think about. And I'm very privileged to actually introduce one of the architects on Singapore's war against diabetes, who is seated here, Professor Alex Cook. He was the mathematical modeler who came up with that troublemaking slide on what is the diabetic burden going to look like in Singapore. And he was also the troublemaker that worked together with our health economist, Professor Joanne Yong, to come up with the analysis on what is the economic burden. So that is actually one way of setting priorities. Now, for the problem like diabetes, we actually have a lot of information on how we can manage the risk factors, because this is just a plot, some information that I got from IHME, from the Global Burden of Disease. And if we look at the known risk factors for diabetes, the vast majority are preventable risk factors. These are risk factors that can be addressed. So it then helped to set our minds, as well as the minds of policymakers, really to think about what is the importance of health promotion or primary care to really address some of the issues I talk about: prevention, early screening, early detection, management and treatment. Because managing a diabetic patient in an acute tertiary hospital is going to cost vastly more than if you can manage it in the primary care setting of as a chronic condition. So I hope I've given you a real-life example on how we could set priorities or to sound alarms and to try and influence what is the agenda at the Ministry of Health or amongst the government's agencies. The next is actually to think about the role of, as academics, we definitely can evaluate policy impact, because part of your basic 101 courses in Masters of Public Health is monitoring and evaluation of health policies and programs. So trying to think about evaluating policy impact. Again, I will use an example, which is the FCTC in thinking about some of the best buys against tobacco. We have 5 strategies that WHO announced. And I suppose the policymakers, when they are faced with recommendations from WHO or from specialized recommendation groups internationally, that it's always the information that is given to them. You think about taxes, you think about packaging, you think about advertising controls, having public spaces that are smoke-free, increasing health literacy. So that is the advice that WHO gave. And you would realize that it happened exactly the same in COVID-19. WHO gave a series of recommendations to all 194 member states. But we have seen how vastly different the same set of advice that WHO gave was executed in all the different member states, leading to very different outcomes. So the policymakers will always be faced with, how do I actually take some of this recommendation, global recommendation, and then address it in a real life setting? So this is perhaps where academics like us can now help to really think about what is the impact of all of these recommendations even before we apply it, or perhaps to evaluate the impact after it has been applied or implemented. So an example of trying to evaluate policy impact before actually implementing it, it's looking at different tobacco control policies. So we thought about increasing minimum legal age. We think about introducing what we would call a smoke-free generation, effectively a generation ban, raising taxes. I started off introducing e-cigarettes to be completely banned in Singapore, but what if we allow e-cigarettes in different forms, including only a prescription-only approach? So then we could look at what is the likely impact and present this information to policymakers. Then they can start to think about whether it is likely to be effective or not going to be effective in their own country context. Because I think what we've learned a lot about public health is that the context specificity is crucial when it comes to implementation and looking at the outcomes. So establishing where the policy works, I think that is one key role that academia can play. The next role is really trying to address some of the gaps in current policies and programs. I talk about the monitoring and evaluation. And this is something that I will use a few examples again from my own country, Singapore, to highlight this. So this is a figure that talks about lower limb amputation as a consequence of poorly managed diabetes. So when you have diabetes that is poorly managed or for extended time, They usually will have problems leading to foot rot or leading to problems, lower limb and problems that you need amputation to take care of. So we compare the amputation rates against OECD countries. Now, there's always that impression that Singapore's healthcare or Singapore's health system is amongst the best in the world. Certainly, if you look at just the longevity index, Singapore is doing very well. In fact, Netflix recently just declared Singapore as one of the blue zones. We can have a talk about that later on. I actually don't think that Singapore is a blue zone. I can give my opinion about that. But where do you think Singapore's amputation rate will fall? You'll be rather surprised to see that we do very poorly. In fact, our amputation rate is extremely poor. It's extremely high. And I will show you another statistics, which is what colleagues within the School of Public Health, my School of Public Health, generated. Typically, in the course of a diabetic patient, it takes about 10 to 20 years of diabetes, if it is well managed, to result in a situation that requires amputation, typically. So remember this, 10 to 20 years. Now, what we realized from looking at the data in Singapore from people who require lower limb amputation, more than a quarter of the data points that we had showed that they learned about their diabetic status only at the point when the doctors tell them that you need to amputate. So what does that mean? What does this mean? Because it means that that person probably has been living with diabetes for quite a long time and without even realizing that the person was diabetic. And that's why it's poorly managed. The rate of degeneration and escalation of complication happens so quickly that they require amputation. And what is the lesson from that? It really tells us that we need to highlight to the policymakers that whatever we think about our health literacy around screening, it is not working. And we need to communicate this even better to population, to the people in Singapore, to get them to come in for health screening. Well, in Singapore, we have commercial sex workers just like any country, any region. And they have specific locations in Singapore where they can practice their trade. But there are a lot of illegal providers, service providers out there around bars, clubs, massage parlors in Singapore. And this would not be governed in Singapore's context because they would not have been legally registered as a commercial sex worker and therefore lose out on all the health checks and health benefits that comes with being a registered commercial sex provider in Singapore. But this group of people that are illegal is still operating their services out there. So for the governments to try and reach out to this group of people to educate them around health literacy, around taking care of themselves, it becomes a rather tricky situation because if I'm a government agency and I know that you are offering services illegally, by right, I should be catching you and then deporting you. But for an academic institution like us, we can actually work with the NGOs out there to look after this group of people and then actually provide the necessary communication and education, which is what my colleague did. And several of my colleagues actually had very illustrious career identifying this group of people, helping this group of people and increase their awareness. And that is very much the bit about protecting health and saving lives. And then, of course, when all of us know how regulatory actions work, it takes months, if not years, of lobbying, of formulating regulations before it gets enacted as law or as a new health policy. But social media trends are changing. Now, these days, my colleague studied the emergence of micro-trends where influencers are telling people what to do, what to eat, vaping, how to get around the laws on getting vaping products in Singapore. And then actually, within this space, these are the guidance that ministries of health worldwide needs to receive in order to tackle rapidly changes advancements in technology, which is one of the megatrends I talk about, the advancements and changes in the technology space, not just always related to artificial intelligence, the use of genomics or wearables, but even in the social media space. Should we have new regulatory laws put in place to think about how to address some of this that are shifting behaviors of populations? So that is another way that academics can work with government policy makers. And finally, of course, there's the bit about, as academics, we tend to be trusted as independent thought leaders to provide communications. And I always like to emphasize that when we think about communications, it is never just to the public. Some of the communication is to the policymakers themselves, whether it is through opinion pieces or through white papers that we put out. It is about trying to socialize ideas to the people that matters, whether it is the public or the policymakers. And of course, one of the roles that I'm very proud of within my school is that we are able to work with governments, with NGOs in Asia to really develop some of these global health case studies to find out what has actually happened, what were the challenges, what were the benefits, what were the policy lessons that we bring in, and then to now make use of some of these case studies in our education space to teach the next generation of public health leaders. And I actually see that this is a very important role that academia can play. Now, I've talked about why it is important. I haven't talked about how. And I think the bit about the how, to try and encourage exchanges. Typically, there are two ways that we in Singapore we think about. One is really the leadership dialogues at perhaps the dean, the vice deans, in the heads of departments interacting with corresponding divisions in the national agencies to really come together and think about what are some of the national priorities that the government has already set, that academia can play a role in, as well as what are some of the priorities that the government may have overlooked that now academics can help to advocate. But that is at the leadership level, because deans and vice deans will know that actually we are quite powerless when it comes to trying to influence what professors do in a university. Because fundamentally, I think Alex has this chart, this diagram about herding cats. Trying to get professors to listen to deans and heads of departments is like herding cats. Oh, well, I need to learn from you, Dean McKenzie. But it's very difficult to get professors to do what really matters to the real world. And in a space like encouraging professors to work with the governments, I think professors will ask, what is in it for me? Would I be recognized if I do this? So there's also a need at the ground level for technical work groups. And this would be where it is not the dean anymore, not the heads of departments, but actually the professors that are passionate about modeling, economic evaluation, social science, behavioral science, speaking to the counterparts in the ministries of health. And that's where having that technical work group discussions will help. And I think with Singapore's ministries of health, we have worked out a workable system where there are regular exchanges with different divisions, whether it's health financing, assessing health technology assessment, looking at epidemiology of infectious diseases, NCDs, cancers, elder care. All these exchanges help to facilitate some of the exchanges. And I will use the last few minutes to talk about some of the examples. So I talk about modeling. And in fact, it is not just around COVID-19 modeling that we were able to help to contribute, but actually it is in terms of different types of outbreaks. We had a group B streptococcus outbreaks amongst people who love to eat raw fish in Singapore. That is not sushi. So when we think about raw fish, people typically gravitate towards raw sushi. But in Singapore, there is a group of Chinese practitioners that love to eat raw fish from Thailand, I think. Thailand. And we had an outbreak. And that's where modeling was actually able to show that had we been able to consolidate national laboratories reporting in a central site rather than for it to sit isolated in each of the different hospitals, we would have been able to detect this outbreak much earlier than what Ministry of Health actually did. So because of some of the work, again, and recommendations, now Singapore has a regime that regularly collates national labs reporting with almost like an AI or a modeling engine that is used to detect outlier signals. And it's not just, I mentioned infectious diseases. I think this was some of the real world questions that were asked from the Singapore Ministry of Health to the School of Public Health in terms of when should we lift our control measures? When should we vaccinate with boosters and how effective it is? Should we use the updated boosters or updated vaccination? And I think all of this actually helped in planning what the national policy was for Singapore. In fact, Alexis and his team was approached from the very beginning, I think on the 2nd or 3rd of January 2020, to model what is the flight pattern coming into Singapore and how rapidly will that drive local transmission in our country. And those information help policymakers to make decisions. Not all the time would they listen to academics, but having that information means that they have the trusted source of data and evidence to think about formulating their policies. I talk about the war against diabetes. Now Singapore, we have a war against sodium because of the rising rate of hypertension. And in fact, it was just yesterday that Singapore announced our latest findings for our nutritional survey and our health survey, where the emergence of the prevalence of hypertension now is about 1 in 3 in Singapore, which highlights the importance of sodium control and sodium measures. And this piece of work was actually already shared with the Ministries of Health about 2 years back. Because they let us know what were the priorities, we can then look at it from our perspective. And I wanted to highlight that we don't just work with the Singapore government. I will just show you 2 examples of what we do in Cambodia, because the School of Public Health at NUS, we have satellite sites in Cambodia and in Laos, 2 countries in Southeast Asia. And in Cambodia, it has been almost 10 years now. We worked across a range of infectious diseases to NCDs. But if we look at some of the activities out there, it's a busy slide and lots of pretty pictures. You could see the range of work that we work on. But more importantly, every piece of work we do will have a natural partner in the Cambodian Ministry of Health, because this allows us then to really feed back what we found, what we discover in our research, into what national policies and programs ought to be. And I think this process of feedback or closing the loop is actually what I always believe schools of public health should do more of, not just in the discovery space, but actually providing that closing the loop to look at how we influence the development or the redesign of existing policies. In Laos, we started this last year, focusing on, again, a range of infectious diseases, including maternal child health, because stunting remains one of the big problems in Laos. How do we address some of this issue? And again, when we look at our partners in Laos, it is not just with WHO officers, with the NGO space. Importantly, we also work with the local governments, such that we are very sure whatever findings and recommendations we make, there is a listening ear at the Ministry of Health. So I think in conclusion, I started off really highlighting megatrends, highlighting problems that the world will face, not necessarily because of health-related issues, but because of the developments in the world that will fundamentally have an impact to health. We heard about the SDGs. We know about the SDGs. They've been around since 2015. The question is, if we believe that we are top schools of public health, what are our actions to drive towards some of the goals of the SDGs, and perhaps to try and help the world in a better? And I think this is again where the leaderships in universities need to adopt the mindset that the traditional definition of success must go beyond publications, grants, teaching, job placements, which are simple metric to measure, but really, are we able to tackle some of the world's problems, even if it's a tiny problem like water security? I call it a tiny problem because if you look at the SDGs, water security is just one very small component of it, but yet I'm pretty sure all of us here will know about the impact of water security, especially in climate changes, in a space of climate change, on the lives, not probably of millions, but hundreds of millions. So in summary, just 3 points. I think partnerships, public health, I'm deeply convinced and very passionate that this partnership ought to be strengthened. And I'm on a mission to try and convince as many schools of public health out there that this is a vision that we should aspire to. But that partnership actually needs to be cultivated during peacetime. Because we saw how when governments during COVID-19, they do not have existing friendship, collaborations, partnerships with credible academics out there. They lack that opportunity to engage a credible source of guidance and input. And trying to reach out to this group of professors in the heat of COVID-19, I think many professors at that point in time will be thinking, wow, how could I capitalize this and get as many Lancet publications as I can? Which was indeed the case, rather than how can some of my work now help to think about what are the national policies around masking, around vaccination, around border controls. And I think this bit about developing it during peacetime needs to be incentivized by the academic structure. And right now, I believe many universities still prioritize an academic structure that favors incentives that are linked to publications, linked to grants, rather than true social impact. So with that, it's been a real privilege and a pleasure to be able to address all of you. Thank you.
Questions, comments? Yes. Oh, there we go.
I can just start.
Yeah.
Thank you, Professor Tao, for your presentation. It's very informative. And I have 2 questions. So as you said at the beginning of the presentation, health is not just health, it's also about politics, right? So during politics decision, there was so many like irrational decision and irrational factors that cannot be controlled just by the university and government. So as you said, like diabetes world has already been launched in Singapore, but I think there might be a lot of like opposition and barrier from the private sector. Like, because if you like launch the world, many companies will lose their interest and people may lose their jobs. So I wonder how you like tackle with this kind of problem. And also build on that, I have a second question. So as you said, during COVID time, a lot of mathematics and health economics modeling the trends or like during other intervention. But I wonder, are you only take the physical health into consideration? How about like the mental health? Like for example, vaping, cigarettes, it still like hurt people's health, but maybe give people like creativity. I know some people like do smoke and they're really happy so far. So this is my question. This is my 2 questions. Thanks so much.
Could you introduce yourself?
My name is Xu Jun, and I'm second year MSP student at Health System.
Thank you. So 2 questions. The first question is, let's start off with the bit about the industry practices. I think in most countries that I know of, the ministries of health generally struggle to work with ministries of trade and industry because of different priorities. And in fact, I talk about the FCTC, WHO and WTO have very different views around certain national, global policies on what is the right tobacco control framework. I think this is where, if we look at the example of sugar control, very specific to diabetes, I think that's where a range of measures have to be introduced. including the regulatory space as well. There's the behavior change component that we need to address, but you would realize that industry fundamentally has profits in mind when they're trying to drive their planning. So the way we think about working with the industry, it's we meaning academics as well as government actors, is actually there is a space that we can collaborate, and that is trying to formulate better, healthier ingredients approach, trying to provide the necessary incentives and even tax incentives to get them to reformulate. But there is a very important space on the regulation side. I will use the example of sugar taxes as well as front of pack labeling changes. Singapore avoided the use of sugar taxes for the time being, but our friends in Thailand, they have introduced a sugar-sweetened beverage tax. And Singapore didn't use a tax approach, but used a front of pack labeling, where now we have something called ABCD, the Nutri grade. If your sugar levels are too high, you get a C and a D, and any products that lies in D cannot be advertised. So when you have that approach, if you're a CEO of an F&B company, what would be your natural response? What we found, and we have actually tabulated some of the changes, is that many food and beverage industry, in order to try and manage what are the perceptions, they will reformulate their products. So what we saw was that there was a reduction in what companies are pushing out that falls within category D and category C, but now they've reformulated to fall within category B. Now, if you use artificial sweeteners, you will never get category A grading. So anything with artificial sweeteners will always fall into category B. And of course, because we know about the latest WHO relabeling of aspartame. Now, what does that do? Because that becomes a rather supply-targeted approach to addressing problems. In Singapore right now, if you go to all the fast food restaurants and you order any sodas, all the sodas that you get by default, it's the reduced sugar version. You will never get full sugared soft drinks anymore in any of the soft drinks, in any of the fast food restaurants. What does that mean? Because people will continue to consume fast food, but because of some of the regulatory actions, now people are consuming a healthier version of the product, perhaps not by choice. Many of them don't even know that the soft drinks that they've gotten right now has been changed to a lower sugar sweetened version. So that's why when I give this talk, I focus a lot on the academic government partnership. But equally, I could give a talk that talks about partnerships in public health in general, to which industries will come in, civil societies and NGOs will come in as well, to look at the overall space that we work in. So I think that's one of the point that I wanted to highlight. We cannot ignore the presence or the power, the influence of the private sector. But how we work with them will have to span across a range of collaboration to look at healthier ingredients, healthier offerings, but also the regulatory space on what are the policy to restrict excess. And I think that's one of the response. The second response, the second question that you have was linked to modeling, is it? And the use of and then what about the mental health space? I hear that a lot because working in public health, I have people who comes to me and say that you guys are the party poopers. First, you say that no sugar. Now, because we just announced the salt information, I had text messages coming to me and say, are you guys now going to make things even more difficult for us to access tasty, savory products? Because is School of Public Health going to champion a war against sodium? Because we were part of the war against sugar. And I think that is when there is always that voice that says, this chocolate cake is not going to be good for me on the physical health part, but on the mental health part, I think it will be great for me. I admit that at the moment, many schools of public health, including my own school, we have not really thought about what is the right methodology to really think about the cost of mental wellness or mental health problems. And we need to address that. I certainly don't have an answer to it. And if there are any of you who have the right answer, I think we should hear about it. But what do we do as public health practitioners? We look at what data is available to us. You talk about vaping. And I think we have data that clearly shows the health consequence of vaping. Now, if it is a reduced harm product, if it is someone who's smoking regular cigarettes and they want to switch to vaping, I think there possibly could be an argument for it. We are not that firm against this group of people who are using it as a reduced harm product. But what we do notice and observe worldwide, including in countries like New Zealand, with an aspiration of a smoke-free generation that is reliant on the use of e-cigarettes to achieve that aspiration of a smoke-free generation, the gateway effect is very prominent, meaning young people are now going into vaping in a bigger way that we have seen compared to regular cigarettes. So for them to come around and say that, well, vaping could be good for my mental health, I think this is where it comes back first to my first point on, do we have the right methodology to measure it? Right now, I don't think I know of it. But what we do know at the moment is the ill effects of certain practices, certain behaviors. And as responsible people, responsible practitioners of public health, I think we clamp down on what we know. When new evidence emerge, then perhaps policies may need to be updated. And I think this is the way the world needs to understand health policies will always change with new knowledge and with additional information, additional innovations. For us to make a claim that health policies are going to be static, I think that is hubristic. And the problem is, I suspect many academics or even public health policy makers tend not to convey that very well. We tend to convey that sugar is bad or eggs are bad for you because of cholesterol. And then that's why there's always that apparent distrust in public health academics that you guys keep changing your tune. Should we wear a mask or should we not wear a mask during COVID-19? So I think that is where we need to have that humility to really present that based on our current knowledge, this is actually not going to be good for you. And we put in place the right policies to and discourage activities in that.
Whoa, lots of questions.
Hi, I'm Gigi Granval. I'm at the Center for Health Security and also in the Environmental Health and Engineering. I have a question. You reflected really profoundly on the work that you've done with politicians and political environments to make the case for public health, especially using cost analysis. Can you reflect a little bit? You could talk about the private sector and the work that you've done there, or other communication strategies for different groups, like students that are not in public health, or the public in general, or private sector that affects the way that public health is implemented.
So we, at the school, I think we try a range of health communication approaches. For example, we work with the national newspapers to really communicate a lot of our opinions that are backed by data and backed by evidence. For example, when WHO reclassified aspartame, actually we released a communication to actually tell people that, you shouldn't have to worry too much about this reclassification. Don't immediately start to gravitate back to sugar. And I think that it's a role that we need to play. And as part of that, you now need to have a different strategy, not forming alliances with ministries of health, but forming alliances with perhaps the media. And media could be traditional media and social media. So that is one part of the work that we realize is important. The other part is actually identifying what are the key actors that influence the development of health. Is it the national development agencies that is looking after water, looking after food security? Is it working with, perhaps even in Singapore context, it's the defense ministry? Because all males are conscripted for a period of 2 years. And post-conscription, we do see weight gains amongst the male because perhaps the exercise levels has dropped, whereas the consumption of calories remain quite high. So I think that's where we have to identify who are the key actors, and then to proactively reach out to them and say, is there a space that we can come together and work together? My colleague, Professor Liao here, he works a lot with the social care sector. And again, now with a major health reform happening in Singapore, he goes to them and asks them, what are your needs in expanding your ability to look after the health of people now beyond just your social care activities? And I think that is also part of the responsibility that we have to do. Now, by the time I finish this talk, you realize that public health professors have to do everything in the world, and they're super people. But that is where the academic structure must be supporting these activities. And I always see it in a frame that it's like you have a vision, and then you have the mission. And I think we hear all this cliche management speak all the time. But once you have your vision and mission, it leads to what are your strategies that you develop as a school, as a department, and then it leads to the structure. Do you have the structure in place? And this is where I look to the university leadership to tell them that I need my professors in practice, because they become a very important group to take the knowledge that is generated by the tenured professors to translate it into the real world, into policies and programs, to provide that level of health communications you talk about as well. Because otherwise, most tenured professors, well, I wouldn't say, well, most is overstating it, but many tenured professors will not think of health communication, raising the level of health literacy as part and parcel of what they should do as a public health academic. And I always come back and say, if you're a public health academic, that must be your basic responsibility, raising awareness and literacy out there. Yeah.
Tom, and then Scott, could you get the microphone over to this table? A couple questions for Tom.
Yeah, great. Well, first of all, thank you so much for that talk. It was amazing. And I think it fits with many of the discussions that we have in this school about trying to make a greater impact with the government. And I know our dean is thinking a lot about this too. And I just want to commend you for the incredible accomplishments of your school. It's got a global reputation. You all are making really important changes in the world. I wanted to ask whether you had, to your last point, whether you all have figured out a process for rewarding focus on government interaction. And you talked about the importance of the practice professors and the challenge maybe with some of your faculty, but have you thought of innovations that help kind of induce or incentivize or reward faculty members for doing more work with government? I think in general, if you look across the United States, as you've just described, it is not rewarded to work with government in general. There are many exceptions, and this school, I think, is one of them, is working to find new innovations. But what do you all do to do that if you've discovered a path? Because we completely agree with you that it's a crucial mission for our School of Public Health. And then a second question related to that is, for the next generation, are you all teaching your students to become engaged with government and the processes of engaging with government? Because it doesn't, even choosing to do that, it doesn't mean that you're good at that or that you know how to engage with government. So are you teaching that in some way? Maybe there's a best practice that is emerging.
Right. I'll try and remember the questions. So the first question, I think we have a working model. I'm not claiming that it's perfect at the moment. So I just shared with Dean McKenzie that in the School of Public Health, we just saw our first associate professor in practice be promoted to full professor in practice. And that was the first case ever that a practice professor was ever promoted in the National University of Singapore, not just in my school, but in the whole university. Because most practice professors come in at a static grade. They come in, and then if they come in as an associate professor, they remain as an associate professor in my university. Now, the way that we were able to encourage this behavior of contributing to practice is actually all linked to appraisals, promotions, and award of tenure. Because I think of it as the carrot and sticks. If you dangle the right carrots, people naturally will gravitate towards it. Right now, most universities' carrot are very much in the space of publications and grants. So what is the carrot that I talk about? So if Alex contributed to some of the work on diabetes war, on COVID-19 policies, when Alex is going up for promotion, the school actually writes to the Ministry of Health for letters from senior leaders, senior policymakers, asking them to articulate what exactly Alex has done and how has that contributed to national policies, changes in national policies, or the launch of new initiatives. Now, because as professors, when we go for our promotion and tenure, what does the university look out for? They typically look for external reviewer letters. Now, external reviewer letters would be obtained from other academics in other universities. And in NUS right now, there is always a preference for for academic letters from United States and from Europe. So if I write to one of you for a letter, there is a very high chance that your lens is going to be an academic lens. You'll be focusing a lot on publications, grants, and teaching. And then you may add, by the way, this person has done well in research, in practice. But if now you ask a policymaker to draft that letter, the letter is actually going to focus a lot on what is the critical impact that has been contributed. So I talk about the case of promotion from associate professor to full professor. We got letters from an international funder. We got letters from WHO. We got letters from national agencies and ministries of health. And those letters were the crucial letters that helped to drive. Now, once we are able to convince the university that we need to have an academic system that respect the nature of the work that the person is doing. Like if I'm going to evaluate someone on a teaching track, I'm not going to be focusing so much on the research profile of that person. I'll be evaluating much more on the teaching leadership and teaching curriculum design, thinking of new ways of pedagogy that is much more in the teaching space. I won't be looking at the person from a pure research academic publication space. So in NUS now, very thankfully, we have a provost and a president that is very forward-looking in a sense that now they say, if you have people whose work is very much grounded in practice work, show us the evidence, and the evidence could be letters from the right people that has been influenced, whether it is from ministries of health or WHO, regional officers, and so on. So I think that has helped a lot. And even in Singapore, we have something called performance bonus, which is you have your regular salary that you get as a professor, but every year, if you do well in teaching, research, or in service, you get an additional financial incentive. And when we evaluate some of the contributions, we take into account the practice part to award the bonus as well. And that actually is a very clear sign that the school recognizes your contribution in practice. So at the school, we have the lever that is called a performance bonus. At the university now, we have that lever that the university recognizes letters from practice agency. And those agencies, when we collect the letters, they provide the necessary proof that this person has actually contributed to policies and programs.
Yeah. Thank you so much for this wonderful talk, and especially about incentives. My name is Ahmed, and I'm an MPH student here. So schools are also driven by incentives, and the schools of law in the US, this has been a major push. They tried US News and World Report rankings to change, but they finally pulled out. And I've seen LinkedIn posts by senior leadership of the school, talking about the focus in the US on US News and World Report rankings. What is your approach to this? What will we work with them to create a space on, ranking public health schools across the world, or will we have to pull out, just like the schools of law have done?
So I'll just show this slide, if I could just go back. Yes, I think this is why. I have to be very careful because I'm speaking in a Western world. This is why when we start to think about the ranking of universities, I will use the phrase, because all of you are global public health people. You know about decolonizing global health. actually we need to decolonize the way that we rank universities. Because fundamentally, if you look at the ranking indicators right now, it is very much in a colonial manner. In terms of, even when we benchmark research, it is research that is published in top ranking journals. Most of them are English speaking. So I think that's where, if you are a university or you are a school that is very comfortable in where you are in the world, actually, are you comfortable enough to say that I'm going to not chase this bit about international rankings, but really focusing on what matters, which is the impact. And this bit is difficult for presidents of universities to accept, because even above the president, there's the board. And the board of the universities are usually very much interested and grounded in the ranking. And then yet, so I talk about above the president, you have the board. Below the president, you have the parents of the students who are now going to say that, what happened? My university used to be ranked number 8, and now it is not even featured in the international ranking. This is a lousy precedent. So I think that is where this phrase about decolonizing university ranking, I'll just leave it as that and for you to think about. But if fundamentally you are confident of the impact that you play in the world, you're confident of the quality of teaching you're putting out, and you're confident of the quality of the research that you're producing, does the ranking still matters? It's a question that I think to you and to me. You are in Hopkins. Why did you choose Hopkins?
Hi, thank you so much for the wonderful talk. I'm Shamini. I'm actually a Singaporean. I'm from the preventive medicine residency in Singapore. I'm just pursuing my full-time MPH here. So let me preface this by saying that I'm so excited to meet your team. I've cited Prof. Cook so many times in my assignments. So it's wonderful to meet you. So my question, firstly, with regards to your presentation, it looks like social impact was a key message that you had. You mentioned at the start and at the end. So with regards to social impact, my question to you is on health equity. I know the School of Public Health in Singapore looks at health equity, but more on a global health scale. And in your slide on megatrends and threats to global health, I noticed that health equity wasn't mentioned in it as well. So my question is on, you have a role, you mentioned, that of advocating to governments, to senior management in the Ministry of Health. So do you advocate for the translation of research in health equity into policy and into community-based interventions?
So thanks very much. And in fact, it was deliberate that health equity was not featured as one of the global megatrends, because you would realize that all of the 6 megatrends fundamentally have an equity lens to it. You could think about urbanization, and then immediately you realize that when you talk about urbanization, there's always a group that is not looked after, particularly in a large country where people migrate from the rural parts into the cities. What is the state of their healthcare provision of that group of people? In many countries, that part is actually very poorly looked after, of the migrants. And I would also preface this by saying that Singapore, during COVID-19, we didn't do very well on the equity side, because one of our biggest problems and biggest gaps in our COVID-19 defense was actually faced by the migrant workers that were working in Singapore and living in the dormitories. So Singapore in itself actually need to also think about how we're addressing the equity issues, not necessarily just health, but in all-round aspect. And since I mentioned the migrant workers, I can mention we are continuing to work with the government, not necessarily Ministry of Health, but in this particular case, the Ministry of Manpower, to tackle this equity space for the migrant workers, to look at the provision of healthcare services for this group of people. But we are excited. We want to set up a center for health equity within the school. So we haven't yet launched it yet. There have been proposals around it, and we have working development plans, concept notes developed on it. I've hesitated to launch the Center for Health Equity in this moment because the timing actually matters. And for us to launch a Center for Health Equity in Singapore, in my school, we have to be able to rightfully say that we have addressed some of the health equity issues that are present in Singapore. Because otherwise, I would face a lot of challenge and criticism if I'm trying to address health equity issues in Southeast Asia, for example, without having addressed the health equity faced by migrant workers. And that's just one group. So I think the equity space, it's challenging, but I agree with you that it's not something that we can ignore.
I think just to tie it back to one of your slides, it mentioned the diabetes prevalence in people over 60, and you had 3 demographics, the Chinese, Indian, and Malay. So the Malays and Indians would be the minority population. The Indians I saw were 6 out of 10 for prevalence. The Chinese were 2.5 out of 10 for prevalence. So besides the migrant workers, I think even our own population
Correct.
faces a lot of health inequity. So it'd be great. I'm glad to hear that you're looking into that.
Yes.
Thank you.
We have time for maybe one more question. Go ahead.
Okay, so thank you so much. Okay, my name is Phonthi Vacharapon. I'm a medical doctor from Thailand and a full-time MPH student here. So my question is about the political interference and academic freedom. So I have heard that some academic institutes, like when they work with government and other organizations and they get some support, like financial support, they may limit their academic freedom. So I wonder that for NUS, you also have that kind of issue, and how do you deal with that kind of political interference and how to keep your academic freedom to lead the public health change?
Thank you very much. And if I have known you were here, I would have sought your opinions on the medical marijuana law in Thailand. So I think this bit about academic independence is very important, because as academics, we lose trust with the people. And actually, I would lose trust with my own professors if I always pander to the government. And hand to heart, actually, to this point, we have never had a publication that was denied by the Ministry of Health when we work with them. No? You have? Oh, he has. So, okay.
Very small number.
And part of the reason it's because we work on the basis of, I'll follow up with you after that to learn which paper was it. Because we work on the basis of the no surprise rule. We have published papers that actually showed how poor the how high the rates of hospital-acquired infections is in Singapore, and which is a direct criticism of some of the health systems, healthcare provision in the hospitals. And what we do is actually we let the Ministry of Health know in advance. And then usually they will come back to us and say that, just don't step us in the back. You can step us in the front, just don't step us in the back. So in terms of political interference, or even interference in the sense of you cannot talk about this particular issue, we haven't faced much of it in Singapore. But again, I have to highlight, we have been very fortunate that we have a group of politicians right now and policymakers right now that are much more transparent in the way they handle. The same degree of transparency may not or will not work in some of the countries. The political interference will be very great. But to some extent, the question then comes back to us again. Do we not work with policymakers because we are worried about interference? Or do we now also try to work with policymakers, but think of clever ways to influence them rather than just always one-sided? And I like to think that, again, as responsible public health academics, it's part of our responsibility to try to influence responsible public policy making in health.
Yeah, it was a very nice talk. I'm Mahua. I'm from India. I am a MPH student here. Before that, I've been working in an Indian academic, Indian Institute of Science, at a Center for Policy Research, which aims to work with the government for policy and evidence research. I would like to know about NUS engagement with the government, more of the how part of it. Are there any liaison centers which kind of works with the government? Because the examples that were given were largely program-based. But is there any model of continuous engagement with the government where the government has a sort of channel to identify the potential collaborators within the university, and also in the university people who are working on things, they know a potential channel to how to work back to the government. So are there any liaison centers such as that?
Yes, and I'm wondering whether I could invite Alex to talk about it, because Alex has been instrumental in setting up some of these channels of interface between governments and the school. And in fact, if I've known, again, you're in the audience, I would have asked for your opinion on India's health financing related to Modi Care.
Okay, so how do we try to facilitate this? Through having regular meetings with them. It helps that we then socialize who we are with them and who they are with us. So that means that, like, I know all of the people from Common Disease Division. I know a lot of people from the other EP divisions. A lot of them are on my WhatsApp, for example. And so that means then that when they've got a problem that they think either I can solve or someone from the school can solve, then it's easy for them to drop me a message or call me up and then say, we've got an issue with, for example, the vaping problem that I spoke about. And then if it's something that I can do, then I'll go ahead and do it. And if it's not, then I'll try to link them up with the appropriate people from the school. So I think that kind of informal channels is really important, but it can only happen by working at it. You don't get a relationship just out of thin air. And so that's where having those regular meetings where we talk about what we have done and they talk about the problems that they're facing, then we can try to organize a research project that will solve their problem, for example.
So actually, I don't have a slide on this, but the school, we have a practice office, and the vice dean of practice is the person who's responsible to interface with the Ministry of Health. So, and the vice dean of practice used to be from Ministry of Health himself, so that makes it a lot easier. So any issues that the Ministry of Health has, it goes to the vice dean of practice, and he can then find the right professor within the school to address it. Similarly, if there's any professors with interesting findings from the research perspective, his office is responsible for taking that finding and then socialize it to the Ministry of Health. And that interface has actually worked out tremendously well. And in fact, I wish there have been a whole range of work that happens between the School of Public Health and the Singapore Ministries of Health. And these are just some examples specifically in health promotion and disease prevention. We haven't even talked about the space in economics, modeling, health financing, and so on. Yeah.
And does it work cross-disciplinary as well, just limited to health or other departments within the university?
So at the moment, this partnership is primarily with the School of Public Health, but within the School of Public Health, that's where we have the opportunity to bring in other people. Alex.
Yeah. So other departments in the university tend to be really blur when it comes to working with the government. They don't know how to get started because they haven't made the effort to try to make those connections for the most part. There are some exceptions, like maybe law, for example. I think one of the other things that we do that helps to facilitate this is we've got funding mechanisms which will allow for our faculty to take on relatively small projects at a minimum amount of administrative overheads. So government pays us a certain number of $1 million a year, which we can then draw down on whenever they've got a problem that they would like one of our people to do. And that's quite a good mechanism for quite small projects for which you don't want to write a competitive grant and then wait a year before the funding results come through, but they need to get something done in the next weeks or months. And so that, because it just requires like a kind of a 2-page sign-off, makes it much more attractive to the cats in my faculty to go on and do something rather than to just wait for $1 million grant, right?
Great. Well, you can see, yes, you can see from the numbers of questions, and I think if we had another hour, we'd have another hour's worth of questions. But it was a fantastic talk, and we really appreciate your being here. And we were talking this morning, and I think it's evidenced by a lot of what you talked about this afternoon. There's a lot of opportunity for partnership. I mean, we have similar visions, mission, and similar goals, and I look forward to a lot more work together. So just before we part, I'd like to give you and your colleagues a little gift. This is bedtime reading. This is the history of the School of Public Health and of public health. 2 volumes. We're working on the 3rd. So, and this is on a little bit lighter note. Just a couple of tumblers with our school logo on it that I hope you can appreciate. Yep.
Southeast Asian Society. We have a scroll, which
It's timed very well.
yes, and it's what we highlighted as the mission and vision of the School of Public Health, of all schools of public health. Yes, it's typed very well, Alex. So you can see that we've been very careful in transporting this. And because we can't actually check this into the plane when you fly here. So Alex has been very diligently carrying it throughout the whole flight. And okay, thank you, Alex. So if I could, okay, so we will hold on to this end.
Okay.
And then I will hold on to this end as we unfold it. So this actually, it stands, it's obviously Chinese characters, but if you read from the right to the left, it actually says health in all population, in the whole population. But if you read from the left to the right, it says building the health or improving the health of all population. And it's really meant to really highlight the vision and mission, in our opinion, of all schools of public health. So a little gift
Thank you.
to
We will
Bloomberg
make it
School of
very
Public Health.